Participants have joined, Shweta, or
Still, we
join,
have just allowed, sir, and still it's not started because
we are live in 3, 2, 1. We are live now.
okay, thank you.
Okay, no problem. Sure. Chandari, shoot.
Sir, let the participant join. Just we will give them the 5 minutes so that they can join.
Yeah. I have to board the flight to Mumbai,
Yeah, I know,
but
sir.
I will open it up. I will stay for some time, and then Dr. Lakshmi will take over. That is how I'm slightly embarrassed, but there is no option. This was
No problem, sir.
yeah, yeah. ಇಲ್ಲಿ ಮುಟ್ಟಿ ಟೈಮಿಗೆ ಬರೋದು अभी उसको टी शर्ट
So, sir, shall we start?
Please, I am waiting for you to start.
Okay, sir. Thank you. Good evening, everyone. Thank you for joining us today for this exciting 38th edition of this webinar on Secret of Neurology. My name is Arun Chada, Vice President in TAS Pharmaceutical, and I'm thrilled to be your host for today's session. Before we go live into the fascinating world of neurology, I would like to extend my warm welcome to our course director, Dr. Sudhir Shah sir, and Dr. Lakshmi Narasimhan sir. And today's presenting Dr. Vijay Sadana sir and their entire team of Government Medical College Kota, and all our participants. Your presence here enrich all the discussions, case presentation, and we are grateful for your engagements. We will cover up the entire session today by 9:30. Shweta, can we move ahead? Shweta, can we move ahead? Yeah. So today is the secret of neurology, and the Government Medical College Kota will present the entire case, and we will end this session by 9:15 or 9:30. Next slide. Next slide. And as far as our course director is concerned, it is very small to say, but they are they have done such a wonderful thing in their lives. And it's very small to as far as to give the introduction to them. But I'll just give a brief of our course director, Dr. Sudhir Shah sir. Sir is the professor and HOD at Srimati NHL MC and SVP IMSR Ahmedabad, and he is a director of neurosciences in Sterling Hospital, Ahmedabad also. And sir is the professor and HOD there and the consultant neurologist at HE, the government of Gujarat, governor of Gujarat also. And sir has having the author of 6 books on neurology and public education, and sir is doing the several publications in the state, national, and international journal. And as far as sir is having the most prestigious award, that is the Padam Shri in 2016. Sir has got Dr. B.C. Roy Award in 2018 and recipient of UNO Award and Global Visionary Award also. And the sir interest is in stroke, neurodegenerative disease, and in epilepsy. And as far as our second course director, Dr. Lakshmi Narasimhan sir, he is the director and professor in Institute of Neurology, Madras Medical College, Chennai. And sir is having so many awards, palliative C advisor from the AIN 2007, A.B. Baker's Award for Global Best Teacher of the American Academy of Neurology, and Best Paper Award of American Academy of Neurology and American Indian Neurology Association 2009. Sir is having a Global Elsevier Atlas Award winner August 2015 and Executive Committee member, World Federation of Neurology. And sir is having a lot of contribution in the neurosciences, and he is the 3-term executive member in the Indian Academy of Neurology and CME convener and Indian Academy of Neurology. And sir has successfully organized 7 consecutive clinical neurosciences program for all India DM postgraduates, SHINE, by the name of SHINE, in till 2017. Course directors, and I would like to now hand over our session to our course director, Dr. Sudhir Shah sir. Over to you, sir.
Thank you, Mr. Chadda. First of all, I welcome all the delegates. It is your continuous support and enthusiasm that has made this series one of the most successful series of learning and teaching. As you know, this is the 38th episode, and many institutions of India have participated month by month, and this time it is turn of Kota Government Medical College, headed by Professor Head Dr. Vijay Sardana. I also at the outset want to thank my co-course director, Dr. Lakshmi Narasimhan, for his tremendous inputs and hard work, which has made this series most useful and popular. I also want to thank all the previous speakers and institutions for their wonderful deliberations, and importantly, INTAS Global Cell Division headed by Mr. Chadda and team for the continuous logistic support. Thank you very much, all of you. So let's start. May I have the previous slide, please, Shweta? Yes. So today, Dr. Kshitish Bansal is going to present the case with the DM resident. Dr. Bharat Bhushan, the assistant professor, will do analysis of symptomatology, followed by Dr. Dilip Maheshwari, senior professor, the same department, who will dissect the investigations and will review the literature. And finally, our learned friend and personal musical friend, Dr. Vijay Sardana, who is a professor and HOD, he will do summary and conclusion. May I have the next slides, please, fast? So, Dr. Vijay Sardana, I know everybody knows a lot about him, but as a part of my formality, I have to introduce him. He is the principal investigator on several ICMR projects, including current PBSR, HBSR, impact to stroke, etc. He has more than 100 national international publication. As I mentioned, currently senior professor and head Department of Neurology of Government Medical College, Kota, but he was recently the vice chancellor and the controller of the university. He has been awarded several prestigious awards, right, from Rajasthan Medical Council Award, Doctor's Day, prestigious G. Haroti Gaurav Award, also merit certificate by district admission in 2004, 2016. Was also awarded Haroti Healthcare Achievement Award 2016 in Times of India, Kota Ratna Award by KG International, and felicitated by Principal and Controller Government Medical College on 15th August 2014 for excellent services. He was FRCP 2020 and so on. Next slide, please. As you know, his other interests are singing and music related things, and he is our chief as far as the music performance are concerned in Indian Academy of Neurology. He has his own YouTube channels and he sings marvelously well. And time permits, I propose we should request him to sing at least a couple of lines for us because he is the voice of Kishore Kumar and others. Dr. Dilip Maheshwari, senior professor, is from the same department and he is also co-principal investigator of certain ICMR projects. He has 42 international and national publications. He has received signature of award by Rotary Club Calcutta of Kota. He was felicitated by principal and controller same way. He was awarded by prestigious Times of India Haroti Healthcare Achievement Award, felicitated by principal and controller Government Medical College, and his signature award by Rotary Club again in 2017. Yeah, and award as token of appreciation by Kota Rotary Club and Anandam ENT Hospital for excellent work in planning of cooperative plan in several deaf patients. And we are all aware of his capabilities as a neurologist. Next slide, please. Dr. Bharat Bhushan is an assistant professor. Today is going to dissect the symptomatology. He is from the same institution and he is also co-principal investigator of certain of the ICMR projects which I mentioned. He has 28 national publications, 2 book chapters, 4 international publications, and he has been recipient of FICP 2022. And interestingly, he was a medicine professor of GMC Kota. Next slide, please. Kshitij is our third year DM resident and is going to present the case of sporadic dystonia with visual loss. I'm sure this is going to be a very interesting case. He has been recipient of first prize for presenting an e-poster titled "A Study of the Correlation of Pulsatility Index by Transcranial Doppler NICE Live 2023 and Best Paper Award in Epicon 2020. His interest is mainly in stroke. Next slide, please. So, ladies and gentlemen, thank you very much for being here. Once again, I thank all of you, especially all the delegates and the presenters. With that, I hand over the mic to Dr. Vijay Sardana, my friend. Dr. Sardana, please, all is yours now.
Sir, before,
Good evening.
sir, with your permission,
Oh,
before,
yes, please. We are here.
before,
Good.
yeah, I just joined for a few minutes. Before
Oh.
Vijay, Professor Vijay takes over, I sincerely thank both Professor Vijay Sardana and Dilip Maheshwari to having agreed to do this in such a short notice. Sir, we are privileged to have you in our session, sir. Thank you so much, sir. Over to you, sir.
Thank you, Dr. Sudhir and Dr. Lakshmi. We are grateful to you to give us this opportunity to present this unique case. Without wasting time, I request our DM resident, Dr. Kshitish, to start the presentation of the case.
Thank you, sir. Good evening, everyone, respected teacher. And I'll be, yes, sir, I'm just sharing my screen. So, good evening, everyone. I'll be presenting the case of a sporadic progressive dystonia with visual impairment. So, our patient, 24-year-old female, right-handed, Muslim female, educated up to 10th standard, born of a second issue of a non-consanguineous married healthy parents, presented to us with chief complaints of abnormal posturing of neck since last 15 years, abnormal posturing of upper limb since last 13 years, and diminution of vision since last 4 years. So history of present illness, our patient presented to us with 15-year history of insidious onset and gradually progressive involuntary, patterned and non-rhythmic contraction resulting in abnormal posturing of the neck, such that her neck used to turn towards the right side, and initially this used to occur occasionally, which later on progressed such that these abnormal posturing remained persistent for most of the time of the day. This abnormal posturing of the neck was associated with involuntary rhythmic tremulousness of the neck, which got aggravated during stress and in public or talking to someone, and got improved by touching the right side of the neck with her hand or turning the head towards the left side, towards the opposite side. And these abnormal posturing got completely resolved during the sleep. And they were not associated with any abnormal posturing of the eyelids and the facial muscles. Since last 13 years, patient developed insidious onset and gradually progressive involuntary pattern twisting and non-rhythmic contractions resulting in the abnormal posturing of her right hand, and which used to occur on attempting to carry out activities and worsened on holding object. This difficulty she noticed initially while writing, such that her writing progressively became illegible. Further on, this worsened such that her wrist used to extend outwards. She also developed difficulty in reaching the morsel of the food to the mouth with her right hand because of this abnormal posturing. And this abnormal posturing of the right upper limb was associated with involuntary rhythmic tremulousness of the right hand while holding the cup or glass of water, and led to a spillage of its content, because of which she started using her left hand for activities of daily living. And this abnormal posturing got aggravated by holding objects and subsided by forming fist. And these got completely resolved during her sleep. She developed similar abnormal posturing in her left upper limb as well since last 10 years. Since last 4 years, patient also developed progressive diminution of vision, which was insidious onset, gradually progressive. Initially, she had difficulty, she noticed this while she was having difficulty in reading in dim light, which later on progressed such that she had difficulty in navigating during the evening and the night hours. Progressively, she started hitting the surrounding objects during the dim light, and this difficulty was not present during the day hours. There was no history of any double vision, no history of any imbalance while walking. Negative history. There was no history suggestive of any diurnal fluctuation of abnormal posturing, slowness of activity of daily living, tightness in any part of the limb, abnormal flinging, stereotypical movement in any part of the limb, no history of any difficulty in deglutition, nasal regurgitation of liquids or change in speech, imbalance while walking, cotton wool-like sensation while walking, numbness or pins and needle-like sensation, no history of any change in behavior, self-mutilating behavior, memory impairment, psychosis, convulsions, or myoclonus. Past history, there was no history of any comorbid illness, In personal history, sleep appetite was normal, bladder bowel habits were normal, patient was non-vegetarian by diet. In the birth history, patient was a full-term normal vaginal delivered, born of a non-consanguineous marriage with no history suggestive of any antenatal, natal or postnatal complications. In developmental history, patient achieved all her milestones at an appropriate age. In the medicine history, there was no history of receiving any of the dopaminergic drugs. This is the family tree of the patient, in which our patient is the only affected member of the family, and this family history is suggestive of a sporadic mode of inheritance of the disease. Now, to summarize the case, our patient, 24-year-old, right-handed female with normal birth and developmental history, presented with 15-year history of insidious onset, gradually progressive, involuntary, patterned, and non-rhythmic contraction, leading to abnormal posturing of neck associated with tremors of the same, with 13-year history of insidious onset and gradually progressive, involuntary, patterned, and non-rhythmic contraction, leading to abnormal posturing of the right upper limb, associated with tremors of the right upper limb, followed by development of similar symptoms in the left upper limb, with 4-year history of diminution of vision, especially during the evening and the night hours, with reduced peripheral vision, without any history suggestive of cognitive decline, neuropsychiatric symptoms, self-mutilating behavior, Parkinsonism, ataxia, diurnal variation of symptoms, without any positive family history. Now I will over to Dr. Bharat Bhushan sir to take on this case further.
Thank you, Sitish. Good evening. And all. Sitish, do it next.
Please carry on. Your voice is not coming properly. Please carry on.
Okay. Okay. I'm coming on symptoms analysis. We have a 24-year-old right-handed female with normal birth and developmental history, presented with the 15-year duration of insidious onset, gradually progressive history along with these 3 symptoms. First symptom was involuntary, pattern, twisting, and non-rhythmic contraction leads to abnormal posture of neck associated with the tremulousness in neck. I would like to define, or I would like to categorize these symptoms in a cervical dystonia, or of course it's a dystonic tremor. Second symptom is involuntary, pattern, twisting, and non-rhythmic contraction leads to abnormal posture of hand associated with the tremulousness in hand. Again, this is kind of a dystonia, but its segment is different, and it's a brachial dystonia type. If you are combining all these 2 other characteristics of this dystonia, we can say it's a young onset dystonia. It's a segmental dystonia history, or I will say type of dystonia, because it's a progressive thing, and the site of onset is from craniocervical side complaint, that is diminished arc with reduced peripheral vision, that is the nyctalopia or night blindness. So these 3 constellations we can categorize in a childhood dystonia syndrome, or our clinical syndrome is childhood onset, sporadic type, progressive, combined dystonia with retinopathy. Next. So our localization is the dystonia. I would like to keep on basal ganglia and its connection of motor circuit, or it's a motor circuit of globus pallidus interna and externa. There is a disturbance in the globus pallidus interna as well as the disturbances or in the substantia nigra. Why the dystonia occurs? It's due to the overactivity of direct and indirect pathway of this extrapyramidal circuit and its connections. Now the second symptoms localization is that is nyctalopia. I would keep on retina. It could be secondary to the any degenerative disease, or it could be secondary to the cytopathy, or it could be hereditary. Because there is a duration of illness is quite long, the gap is around 4 years. Now, according to this consideration of these two symptoms, that is the segmental type of dystonia, I would keep three etiology or etiological diagnosis, differential diagnosis are: number one is of course the Wilson disease. Why Wilson disease? To look as a treatability and its a response with the treatment. I would keep it is a Wilson disease. Wilson disease is a first differential diagnosis. Second, I would keep PKAN, that is pantothenate kinase associated neurodegeneration. Third differential diagnosis, I would keep HARP, that is pre-beta lipoproteinemia, acanthocytosis, retinitis pigmentosa, pallidal degeneration, because it is having some allelic association with the PKAN. That's why it's my third differential diagnosis etiologically. Now, of course, the less likely the mitochondrial cytopathy, we can keep it here with these only two symptomatology or two signs of patients. Now, why these Wilson disease and why not these Wilson disease? The points here for Wilson disease are: number is the younger age of onset. Second thing, there is a this is a young onset dystonia. Why not we are keeping history suggestive of the Parkinsonism? There is no history suggestive of any behavioral changes. There is no history suggestive of psychosis. There is empathy. So we are not keeping this because these are the usually not found in the Wilson disease. My second differential diagnosis, which is that is PKAN. The point here for PKAN is, of course, there are other symptomatologies are not there, but the point against are for this PKAN, these are the cognitive decline, Parkinsonism features, or some there is a orofacial dystonia are not there. So we can think another allelic probability, that is heart disease. In this heart disease, again the points favor are as age, that is younger age, and the dystonia is a secondary dystonia, and there is presence of retinopathy. But points against are, again, there is there is no history suggestive of any Parkinsonian features in our history or in our detailed summary. And again, there is no history of suggestive buccolingual dyskinesia. That's why I'm making it's not a case of harm. Now I would like to invite Dr. Sitish, kindly carry forward.
Yes, sir.
Proceeding of this case.
Yes. Thank you, sir. Now I'll be coming to the examination part. So in the general examination, our patient was average build with good nourishment. The pulse was 74 per minute and regular. The blood pressure was within normal limit and there was no orthostatic hypotension. In general physical examination was within normal limit, and in the systemic examination, CVS, respiratory and per abdominal examination was also within normal limit and there was no organomegaly. In the neurological examination, higher mental functions, patient was conscious oriented to time, place and person. MMSC, MoCA and FAB battery test was within normal limit. Speech was also within normal limit. In cranial nerve examination, the pupils were normal. The visual acuity in the right eye was 6/36 and in the left eye was 6.24. and which got improved by the pinhole to right eye by 6/12, and in the left eye it was 6/9. And the field of vision and color vision was within normal limit bilaterally, and the KF ring was not seen, which was an important examination finding. And in fundus examination, bony spicule pigmentation was seen bilaterally in the peripheral retina, which was suggestive of retinitis pigmentosa. And rest retinal examination was within normal limit. In motor examination, the bulk tone was normal, power was 5/5 bilaterally, DTRs were +2 bilaterally, and there was no hyperreflexia. Plantars were flexor. Sensory, cerebellar, and gait was within normal limit, and meningeal signs were absent. In the involuntary movement, we confirmed the cervical dystonia was of torticollis type with obvious dystonic tremors, and the null point was in the left lateral rotation. And in the upper limb, it was an extensor type of wrist dystonia. In the extrapyramidal symptoms, there was no bradykinesia and there was no rigidity. So this is the video of the patient in which we can see the patient is having torticollis with obvious dystonic tremors, and now the patient is trying to achieve the null point, and also she is doing the sensory trick also. And in this, we can appreciate the extensor type of wrist dystonia. And when she holds the glass of water, this dystonic movement increase, and she is also helping the spillage of the contents. And if we see, especially in her left hand, she is having a similar mirror movement in the left upper limb as well. So by seeing this, we can confirm that the patient is having torticollis along with the extensor type of wrist dystonia with similar mirror movements in the left upper limb as well. So after examination, the points confirmed were the patient is having retinitis pigmentosa, the cervical dystonia is of torticollis type, the hand dystonia is of extensor type, and there was no KF ring. So after examination, our differential diagnosis now, the Wilson's disease is negated, and the two main differentials remain are pantothenate kinase associated neurodegeneration, that is the PCAM, and second is the hypoprebital lipoproteinemia, acanthocytosis, retinitis pigmentosa with palladial degeneration, that is the Harv's disease. Now the investigation part. These are we got done the routine blood investigation in which the hemoglobin, TLC, and platelet counts were within normal limit. The RFTs and the LFTs were within normal limit, and the electrolytes were also normal. The viral markers were negative, and in the lipid profile was also normal. Especially, we looked for the VLDL, which came out to be within normal limit, and the creatinine kinase was also normal. And we also got done the serum copper, ceruloplasmin, which were again normal. Serum ferritin and vitamin E, which were again within normal limits. And in the PBF, we repeated thrice to look for the acanthocytosis, and there were no acanthocytes seen in the peripheral smear even after doing repeatedly. Now the electrophysiological studies, we did the nerve conduction studies along with the VEP and BERA for the patient and as well as the parents, and these were within normal limit for both patient as well as the parents. And in the fundal photography, there were early retinitis pigmentosa changes in the patient, while they were not seen in the parents. So the nerve conduction study, VEP and BERA and the fundal photography were normal in the parents, and in the patient, only fundal photography was suggestive of early retinitis pigmentosa changes. Now I will over to Dr. Dilip Maheshwari sir to take this case on further.
I want to share my slides, but it is mentioned that you cannot start screen share while the other participant is sharing.
Yes, sir. I have stopped the sharing now.
Okay. Okay. So now I would like to share my slides. I will go to the screen. Am I audible?
Yes, you are audible.
Yeah. First of all, I would like to give congratulations to all human beings on this earth with the soft landing of the Chandrayaan 3, and that Chandrayaan 3 is very informative and very helpful for our future generation to develop the various internet and space activities. Secondly, I would like to give the thanks to our thanks to the organizers to give us the opportunity to the Department of Neurology on this great platform, and this is the 38th consequent subsequent case presentation, very academic fest. So I would like to discuss about the further investigations of our patient. It is very important to see that when you do all the good clinical history, good clinical examination, I would like to give thanks to Dr. Kshitij Bansal and Dr. Bharat Bhushan. They have made my work very easy to proceed further. This is a slide of MRI of the same patient of T1 weighted sequence, and you can see the normal anatomy and there is no abnormal finding. The second image is, you can see the again detail of the T1 weighted sequence of the same patient, which is showing only subtle cerebellar atrophy, otherwise cerebral cortex, brain stem and other structures of the brain, minor structures of the brain, all normal. And you can also see in the T2 weighted sequence that there is no abnormal finding in any part of the basal ganglia, and only except there is some subtle cerebellar atrophy which is seen in the sagittal section. This is a FLAIR sequence which is also not showing any specific pathological finding. So then we went for the GRE sequence because our differential diagnosis which were limited to the PCAN or HARP syndrome. So we were expecting some iron overload in the brain, but this 1.5 Tesla is again normal and GRE sequence is also normal. So what we did is, what we were expecting and what we have done. So what we were expecting, according to the literature, that it was my duty to show the literature and evaluation of literature, that in the literature it is mentioned that if you see such type of patient, this was our expectation, which this presentation we have taken from the Journal of Movement Disorder and published in 2015. Here you can see very well that there is a central bilateral symmetrical central hyperintensity in the globus pallidus, which is surrounded by anteromedial symmetrical hypointensity. This hyperintensity is because of the necrosis and spheroid bodies in the globus pallidus, and this hypointensity is because of the iron overload, which you can see in the globus pallidus, and also if you see at the substantia nigra here, so this is also seen in the substantia nigra. So this is the journal I have reviewed, and this is the why this is called as a eye of tiger sign. You can see this eye of the tiger here. There is a central hyperintensity which is surrounded by the hypointensity. So left eye correlate with the right side and right eye correlate with the left side of the brain. So hypointense globus pallidus and hyperintense anteromedially. This was the finding we were expecting. But the real essence of the neurology is when you have done the all examination, but there is no finding in the imaging. This is the where actual role of the neurologist comes. So then we reviewed the literature, that where was the mistake or what was the problem, why we were not able to find out the eye of the tiger sign which we were expecting. So we reviewed a literature journal which was published in Journal of MRI in 2012. There is confirmed case of missense mutation without eye of tiger sign, but there was this is a large group of the patient they have evaluated, and out of the confirmed PCAN 20 patients, only 6 patients were not having any specific eye of tiger sign, which is a very important sign. We were expecting iron overload in our patient. So but this is another case report of the 2 cases in which there was a confirmed PENK2 gene mutation but without eye of the tiger sign. This is again published in Journal of Neurology. Then the eye of tiger sign may be absent in the early stage of the classic pantothenate kinase associated new generation, but our patient was having 13 to 14 years of history, still it was not there. So what next? What we have to do? So with this, because we are presenting this case on the national form, and in the 1.5 Tesla MRI we were not finding the exact eye of the tiger sign. So our head of department advised us to go for the higher Tesla MRI, high field MRI. So we went and we tried to manage to do the high Tesla MRI free of cost because our patient is not affordable for that. And this is the 3 Tesla MRI we have done. And this is classical. There is a central hyperintensity you can see in the T2 weighted image in the globus pallidus, and there are bilateral symmetrical hypointensity surrounded by hyperintensity. This is seen in the susceptibility weighted image of the 3 Tesla MRI. So this is very important that you have to go for the 3 Tesla MRI, especially when you are looking for the iron overload. This is a non-invasive procedure or non-invasive imaging in which we can see for the iron overload. But the important thing we should always remember that eye of the tiger sign can also be seen in normal patients. So you have to take care for that normal patient with 3 Tesla MRI. This can also be seen in atypical Parkinsonism and sometimes in the Wilson disease as well. Sometimes can also be seen in the organophosphorus poisoning. So you have to take the clinical history and finding with your imaging finding. So what next? So after doing this MRI, we did the fundal photograph of our patient, and these are the right eye and left eye. In the right eye, you can see there are peripheral bony spicules which were confirmed by our ophthalmologist, senior ophthalmologist, and there were narrowing of the retinal vessels, and there is mild pallor optic disc. So you can see here in the circle there are bony spicules seen very well, and there is a central hypointensity in the and there are thinning of the retinal vessels. So it is my duty to explain about the retinitis pigmentosa in this patient, because in the literature it can present in 3 stages. In the early stage of the retinitis pigmentosa, patient may have peripheral visual field defect, which may be, and the fundus may be absolutely normal, or there may be sometimes few bony spicules we can see, and there will be modest attenuation of the retinal vessels, but optic disc remain normal. This is the mid stage. Like in our patient, there will be obvious night blindness. The fundus examination will show bony spicules as in our patient. There may be some atrophy of the retina, narrowing of the retinal vessels, and moderate pallor optic disc. The end stage of the disease, in the literature we found that the patient will have classical presentation of tunnel vision, patient becomes dependent, intense photophobia, and patient fundus will show macular involvement. So because of the macular involvement, patient become dependent. There is widespread pigment deposition, very thin retinal vessels, and optic disc become waxy pallor. So coming to this next step, after doing the good clinical examination, history, followed by MRI, and then looking at this retina finding, we narrowed down our diagnosis under the umbrella of NBIA, that is neurodegeneration with brain iron accumulation. So how to approach for a patient with the NBIA? So to approach in a case of NBIA, because this is an umbrella term, under the NBIA, there are many differential diagnosis comes. So how to narrow down? So first, the clinical presentation with any movement disorder, a variable degree of pyramidal, cerebellar, peripheral nerve involvement, autonomic, cognitive, or visual dysfunction. So our patient was having movement disorder with visual dysfunction. The second important thing is we will do the MRI directly. And by doing the MRI, you can see hypointense on T2 susceptibility weighted images in the globus pallidus, which is characteristic of iron accumulation. And here we can rule out by doing the CT scan basal ganglia calcification. So after making this MRI and clinical finding, we made that this is a case of NBIA. So after that, we will see the family history. The patient is having recessive or dominant. So our patient was having recessive problem. So if you look at this next step, if the patient is having strong family history, dominant presentation, then the diagnosis is an adult onset. The diagnosis is narrowed down to either neuroretinopathy or aceruloplasminemia, which is usually seen in the adult patient in the 3rd or 4th decade, and the MRI will be a little bit different. That patient may have intense cerebellar atrophy, iron deposits may be seen in uh, um, other than globus pallidus like putamen, pallidum, thalamus. So this is excluded by just doing the history and taking the family history. We can exclude these two important diagnoses. Although we have investigated for this, the ferritin level was normal and ceruloplasmin levels were also normal. Sugar was also normal. So these two diagnoses under NBIA are ruled out. Now going to the recessive form, in our patient, we were expecting the PCON, either typical or non-typical form. Atypical form, patient will have pigmentary retinopathy. So this is fitting in our patient's finding. The other ophthalmological examination like PLAN, COPAN, FHN, and MPAN. These are the different NBIA disorders are of autosomal recessive pattern. Although most common is PCON, which is seen in the 50 to 60% patient, PLAN is seen in 20 to 30% patient, and other disorders are rare. But looking at the ophthalmological finding, we can narrow down our differential diagnosis with the PCON because we are having pigmentary retinopathy. The PCON can be further divided at the age of onset. If it starts in the early age, before 6 years of age, then it will be a typical, and if it starts after 6 years of age, it will be atypical. So late onset are atypical ones. So what is the MRI finding? Eye of the tiger sign, PCON. If the marked cerebellar atrophy, it will be PLAN and many others. So now we have to discuss, now I am going to discuss about it is always important to know about the history and what is the difference, most important diagnosis you are discussing. So in reviewing the literature, this PCON was initially invented by Hallawadden and Spage. So this syndrome is known in 1922. This was labeled as a syndrome of Hallawadden and Spage. But these are the German neuropathologists, and they were affiliated. They have affiliated with Naji's population, and they were doing unethical many autopsies they have done without proper ethical approval, and so this name of Hallawadden-Spage syndrome is discouraged. So we have finally named it as a PCON, that is pantothenate kinase associated neurodegeneration. So what is the most important finding in the PCON is PANK2 gene, because of the very short time period given to us. And second thing is, it is very costly investigation to do the genetic testing. We were not able to get the report of PANK2 gene mutation. But I can discuss that some most common mutation in the PANK2 gene is missense mutation, which is seen on the short arm of chromosome number 22 at the location 13. So this missense mutation was most commonly seen. Other mutations which we can see in the PANK2 gene are the duplication, deletion, splicing. So there are 7 different exomes and having different kind of mutations. So the patient can have different phenotypic presentation. Coming back to what is this PANK2 gene is going to do? So this PANK2 gene is responsible to produce the protein pantothenate kinase 2. This is the first key regulatory step of coenzyme biosynthesis, in which this enzyme is utilized, and this coenzyme A is essential for the intermediary and fatty acid metabolism. This coenzyme A is utilized by the mitochondria of the brain cells to do the homeostasis with the various metals and heavy metals. Coming to the next slide, the pantothenate kinase associated neurodegeneration can be divided into 2 subtypes. One is classical PCON and another is atypical PCON. The classical PCON usually starts before the 6 years of age, and this patient may come with the opistotonic posturing. He may not able to lie down on the bed, and patient may have the lower limb dystonia. This same patient can also have retinitis pigmentosa. This patient, classical type of PCON, have very rapid progression, which is not linear but stepwise. And patient can in advanced disease develop the bulbar symptoms, and because of the complication, patient may succumb in the first decade itself. And if the patient survive even after the first decade in adulthood, he will have a severe disability. So disability is a very important part, because this patient turned to our hospital only for the purpose of to get the disability certification. So we admitted this patient to make the diagnosis and to make the proper disability grading of this patient. He was having, according to the IDEAS criteria and other functional disability, our patient was having 45% disability. So this is a second variant of atypical PCAN, which starts after the age of 6 years, and our patient was having upper limb dystonia, bilateral neck dystonia, so brachial segmental dystonia. These patients of atypical PCAN will have more dystonia than Parkinsonian feature, not like typical PCAN. The patient can also have dysarthria, spasmodic dysphonia, or oropharyngeal dystonia. But similarly, here also patient may have pigmentary retinopathy, but this will not that much severe as we can see in the typical PCAN. So again, because our second differential diagnosis was HARP syndrome, is mentioned by Dr. Bharat in his analysis of the symptom and differential diagnosis. This patient can also have the eye of the tiger sign. But the important finding is hyperpyribeta lipoproteinemia and acanthocytosis. As Dr. Kshitij already mentioned that we have done peripheral blood smear for 3 times, but there was no acanthocytosis seen in any of the PBF. And for the pre-beta lipoproteinemia, it was not possible to do for us because it was a short time, and the affordability of the patient was very poor. So we have taken the indirect evidence of VLDL. If the patient is having hypoprebeta lipoproteinemia, VLDL will also be absent or very low. But our patient was having normal VLDL. So HARP syndrome patient may have, it's a rare neurodegenerative disorder. It's an autosomal disorder, recessive disorder. Patient may have rigidity, motor disturbance, involuntary movements, and mental deterioration. This is the serum protein electrophoresis. Just for the academic purpose, I have added this slide, that if you can see that there is a pre-beta lipoprotein band is seen in the center, agarose gel electrophoresis, a normal pattern, this patient will have this band. If a patient is having HARP syndrome, then this band will not be seen in our patient, will be seen in the HARP syndrome. So what next? The important thing is, in our days of residency, we used to say that in the neurology, you just diagnose the patient, discuss the patient, and discharge. There was no part of the treatment. But in the over last 2 decades, I have seen that there are many treatment available for different neurological disease. So here I would like to unveil the solutions for our patient. What is the solution for our patient is, first we will go for the symptomatic treatment, and then we will go for the specific treatment. In the symptomatic treatment, it is dictum that whenever a child coming with the dystonia, it is always good to try a dopaminergic drug like levodopa to look for or to rule out the dopa responsive dystonia, which is easily treatable. Then you can also see the response of anticholinergic drugs like trihexyphenidyl. You can see the response with the tetrabenazine and baclofen. These are the 4-5 drugs which we can use symptomatically with modest or mild benefit. The injection botulinum toxin is freely available in our institute. We have given 170 units of botulinum toxin in neck muscles and extensor group of the hand muscles, forearm muscles. And with that, we are expecting that at least patient can do his activity of daily living with both the upper limbs. Then what is the latest is surgical procedures. You can do the thalabotomy, palidotomy or deep brain stimulation. In era of 90s, thalabotomy and palidotomy used to be done, but because of their permanent nature of the lesionectomy, DBS is preferred. But overall result, according to the literature, we can found that almost 30% the 30% improvement can be seen in the patient symptom, but it is not going to affect the long-term outcome of the patient. Now, because this is an iron overload disease, so that idea was that we can use the iron chelating agent in these patients. Of course, yes, we have given, there is a TIRCON trial, that is treat iron related childhood onset neurodegeneration. In this trial, they have tried lot many patients to give the deferriprone. So I will discuss this in the next slide. And we can also give the supplement in the form of pantothenic acid, which is an intermediary compound of the vitamin B5, which is freely available in the market. So phosphate pantotenate replacement therapy was also given, and there are trial available. So now I would like to show you some trial. There is a safety and efficacy of deferriprone in the Pecan disease. It is a randomized double-blind controlled trial, open label study. And what was their conclusion? They found a mixed result. Some patients showed improvement, subtle improvement, some patients did not show improvement. The important message is deferriprone was well tolerated, achieved target engagement, it lowers the iron load in the basal ganglia, seemed to show somewhat benefit in the disease progression up to 18 months. So this is the study which is done for 1.5 years, although the results were not that much significant. Another drug was tried is phosphate-pantotenate. It is a metabolite of pantothenic acid which is used in RCT, but according to the literature, it did not improve the function assessed by the Pecan ADL. So with this, I conclude my investigation evaluation, and I would like to invite our professor and head, Department of Neurology, Government Medical College, Dr. Vijay Sardana sir. Dr. Sardana sir, over to you. So
Thank you. I think it was a nice presentation by all, clinical investigations and evaluation part, and the details of the diagnosis which we have made. The good old Halvorsen-Schwarz disease, when we used to be student or appearing in the DM examination, this used to be a famous MCQ, now has changed to PKN. The case has cardinal features: dystonia, which is likely to be secondary with the retinitis pigmentosa, and lack of other cardinal symptoms and signs normally we see in neurodegenerative disorders. Now, when do we suspect secondary dystonia? Secondary dystonia is suspected when you have etiological history of perinatal problems, encephalitis, head and neck trauma, peripheral injury, toxins of drug exposure, sudden onset dystonia, and the dystonia with rapid progression, and when we have onset in infancy. When we have cranial onset in childhood, then also we suspect dystonia, like in this case. Onset in legs in adulthood, hemidystonia, fixed posture, early speech involvement, and abnormal neurological findings like dementia, ataxia, seizures, which were not there, of course, in this case. Ocular and visual disturbance were there in this case, in the form of retinitis pigmentosa. Ataxia, weakness, amyotrophy, spasticity, areflexia, sensory deficit, Parkinsonism, dysautonomia, systemic and skeletal abnormalities. So we had a very limited presentation in this case, dystonia with visual disturbance in the form of retinitis pigmentosa. We also suspect secondary dystonia when we have evidence of psychogenic etiology, abnormal brain imaging, abnormal lab studies. Next, please. Now, the next set of combination is movement disorder associated with retinitis pigmentosa. That's the main catch in this case. The first possibility, these are the possibilities listed, you can see. N by EA, PKN is the one possibility which we have considered strongly, predominantly on clinical basis. Some investigations like MRI 3 Tesla is helping in that. Aceruloplasminemia looks unlikely because normal ceruloplasmin, these patients have failure to thrive, may have that also. And the next possibility, HARP, as Dr. Dilip said, that VLDL in this patient was normal, so that also looks less likely. A-beta lipoproteinemia can have retinal degeneration, but then these cases will have earlier onset, failure to thrive, and peripheral neuropathy associated, which was not there in our case. And the next possibility, which can be considered, is hereditary ataxia with vitamin E deficiency. Almost the clinical presentation is similar to A-beta lipoproteinemia, early onset failure to thrive, pseudotoria, and peripheral neuropathy, which is not there in this case. Least disease, we know, is very early onset. Most patients will not survive beyond 7 to 8 years. And they have normally seizures with cognitive decline and peripheral neuropathy, which is not there in our case. NARP, patients will have predominant ataxia, which was not there in our case. Early childhood age can match our case, but then there was no ataxia in our case. PHARC will have again predominant ataxia, which was not there in our case. SCAs, of course, will have predominant ataxias, and adenoleukodystrophy, we all know, has a particular set of clinical symptomatology and signs. So this was also unlikely in our case. Next, please. So what is the take-home message of this case? You know, sometimes you enjoy evaluating bit by bit the cases which give you partial clue. And in neurology, this is the beauty of neurology, then clinical neurology teaches you much more than acute neurology as far as the reasoning and the critical thinking is concerned. What we learn out of this is that dystonia, especially when suggestive of secondary form, should always be thoroughly searched for etiology. When overlooked, sometimes we don't bother to look for the fundus examination because of shortage of time or whatever reason. When done, sometime it can lead to very important diagnosis, like in this case. We can pick up retinitis pigmentosa. Dr. Maheshwari has told what are the signs of early, mid, and late retinitis pigmentosa. Age of onset and distinctive limited clinical feature, like in this case, dystonia and retinal involvement, fortunately limits the differential diagnosis. So, we were eased out by these limited clinical features and age of onset. And initially, as explained, the imaging 1.5 Tesla was normal, but then later on, when we went for 3 Tesla imaging, it was suggestive. So in such cases, 3 Tesla, maybe more than that, should be exploited, and so that we can give a correct diagnosis to patient and we can educate ourselves. Trials, all those trials which Dr. Dilip has told, have not been successful, like most of the degenerative and similar disorders. but then we should be hopeful for the future that something or the other will come out. Research will show some of the other treatment or some of the other modalities which can benefit these patients. Next, please. I think that was the last. Thank you very much. Thanks for the patient listening. Over to organizers and over to
Thank you, sir.
Dr.
Thank you.
Nas-
Thank you, Professor Siddhana. Wonderful case, wonderful disposition of the dystonia, especially for the youngsters. I really enjoyed every second, especially the PCAN. My sincere thanks to Dr. Dilip Maheshwari. And as Sarah has put, the classical Chandrayaan 3 is an inspiration for all of us. I just wanted to, for the sake of post, I just wanted to add one thing is, for retinitis pigmentosa, now we have the FDA approved Argus 2 / retinal prosthesis, which at least gives them some useful side. I've seen a couple of patients who got it from Germany, who are using the Argus 2 retinal prosthesis, were able to have a definite useful return of vision to them. So that is one aspect which I just thought for the sake of just to add. So
I think that's a very nice piece of information by Dr. Lakshmi.
yeah, it's an FDA's approved Argus 2 flash.
You're not audible,
retinal
Dr.
process.
Lakshmi.
There are three. This is called. There are 2-3 retinal processes. One is called second sight also. They're all, and there are a lot of after the advent of the synchronization of bio-digital interface, the ganglion cell layer can be bypassed, taking the input from the before the ganglion cell layer, and can be bypassed and put into the put into the optic nerve distal to the ganglion cell layer. And another interesting thing which one should know is, I'm always following this sensory substitution devices. Initially the optic nerve is not just takes only the visual. The optic nerve impulses, if they are given to spiral ganglion in the auditory nerve, it will home to the occipital cortex. And this was one of the landmark discovery in 2015, and that opened up the new era of called sensory substitution devices. I want the postgraduates to read. Most of these cables, the optic nerve or the acoustic nerve, are not modality specific. All these years we were thinking they're all modality specific. They're not modality specific. They are task specific. You can put auditory impulses into the optic nerve, it will go home to the primary auditory cortex by the neural networks. So this I want you to understand. That is the basis of the beautiful area which has emerged in the neuro rehabilitation in the form of sensory substitution devices. With these 2 points, my hearty thanks to Professor Vijay Siddhana. Thank you so much, sir. Dilip Maheshwari and the presenter, and Dr. Bhushan, Bharat Bhushan, every one of you who gathered, and thanks for a wonderful intellectual piece. And
Thank you, sir.
Thank you, Dr.
Thank you, sir. Thank you.
You're really, I'm very, very happy today, because the kind of you won't even get in anywhere, sir. I was so surprised that especially the pre-beta faction, the lipoprotein electrophoresis, and I'm really amazed. First time I'm seeing, in fact, first time I'm hearing that also. Thanks to all of you for the wonderful night you gave. Over to the INTAS people for conclusion. Thank you.
Thank you, sir. Today it's really a great day as we are completing the 38th session of the Secret of Neurology. I, Arun Chadha, Associate Vice President, on behalf of INTAS Pharmaceutical, would like to propose a hearty vote of thanks to all the honorable delegates who blessed us with their presence in the last 38 months. And I would like to thank our honorable course director, Dr. Sudhir Shah sir and Lakshmi Narasimhan sir, for designing such a fantastic web series on neurology, which will be very helpful to all the DM and DNB students. And we are very thankful to young neurologist, Dr. Kshitij Bansal, for the case presentation. And further to this, I would like to thank Dr. Bharat Bhushan sir, Dr. Dilip Maheshwari sir, for the case analysis and differential of the cases. And thanks to Professor Dr. Vijay Siddhana sir, who is the Senior Professor and HOD of Neurology, Government Medical College, Kota, for sharing their experience in the case and providing the important learning points and proceeding of this unique case. Once again, we are very thankful to all of you for your gracious presence. It's being clear, being with all of you, for today's 38th, that is a session of Secret of Neurology. And thank you all for your presence. And we'll meet again on 29th September 2023 with yet another most awaited next session of Secret of Neurology. Till then, stay safe and take care. Thank you. Thank you to all of you.
Thank you, sir.
Thank you, sir.
Thank
Thank
you.
you very much.
Thank you.
Thank you
Thank
so
you,
much,
Mr.
Vijay
Chadda.
sir.
Thank you.
I think it was a noble initiative you have thought in consultation and in guidance with Dr. Narasimhan and Dr. Sudhir Shah. And it will benefit many budding DM students and neurologists. And, exercise of critical case presentation and learning is always there for even senior neurologists. So I compliment you and your company for thinking and supporting this initiative.
Thank you. Thank you very much, sir. Thank you. Thank you very much, sir.
Thank you.
Thank you so much, sir. Thank you,
Thank
Dilip
you,
sir.
sir.
Thank you,
Thank you.
Well-Bhushan sir. Thank you, Dr. Shadej.
Okay.